صباح الخير. مناسبة انه احنا في مكتبة محمد بن راشد يحضرني بيت المتنبي اللي يقول: أعز مكان في الدنا سرج سابح وخير جليس في الزمان كتابه. صباح الخير جميعا وشكرا على الاستضافة وشكرا على اختيار هذا المكان الجميل. Today I'm going to talk about the different changes of environmental, commercial and ideas that are roaming around the world that will definitely be changing the face of healthcare as we know it. The face of healthcare that we trained through and worked through and probably experienced as patients or carers or relatives of patients is changing. There are so many changes that it's making it quite difficult, the most prominent of which are three. So the AI, the precision, and the talk about longevity. So I do next, well, you guys do next. Okay. So all stems from different challenges. I think you all know about the biggest challenge of all. As we advance in terms of the way we live and the living standards that we experience, our age becomes a bit longer. So today, the average age in Europe is about 84. The average age in UAE is about 81, but it keeps increasing. What this brings, of course, we are having more time to enjoy ourselves with our families, with the hobbies we have, as well as the passions that we occupy, but also it allows the creeping of chronic diseases, which brings a burden on the healthcare sector. So today, anybody who's above the age of 50 will have about 30% chance of experiencing a chronic disease. When you reach above the age of 80, all of us will have at least 2 chronic diseases. What this does is it will put a lot of pressure on the healthcare sector to deal with it. Also, something that we experienced during COVID, which is the resilience of system that we work with. So everybody experienced what happened during COVID. Everybody started and now appreciate that healthcare today is not only healthcare. It's not about hospitals, it's not about clinics. Healthcare today is about education. Healthcare today is about economy. Healthcare today is about resilience and security. So everybody, all of the other sectors are working together, and there's the new concept that we call One Health. So One Health is about bringing all the different elements of society to focus on health, improving it as we go along, as well as providing the facilities to manage it if it goes wrong. And then there is rising health inequality. So today, rising health inequalities, when we talk about the life expectancy in Europe being 84, when you look at sub-Saharan Africa, the life expectancy is about 62. There's about 22 years difference between these two localities. Not because humans are different, it's because of the access and inequality to healthcare. Not only the basic need of healthcare, but also the high quality healthcare. So even today within UAE, there are different accessible parameters for healthcare. So there's access in terms of gender, access in terms of nationality, access difference in terms of age even. There are certain things that can be provided, certain things cannot be provided, or certain hospitals or certain clinics can be or cannot be provided. So that inequality will also leading to what we call growing workforce shortage. It's not only the UAE, it's not only the GCC, it's a wider world problem. The access to talent is always, that is always in high demand, is getting higher and higher and more difficult by the day. What this leads us is always there is the element of doing 3 things, which is training your own talent, retaining the talent that you are already having, as well as attracting the talent that you need. And the talent today is changing. So the talent when we grew up, when we got trained, is all about providing doctors that are super specialized in different areas. Nowadays, we need the talent to be able to cope with the technological changes and the face of the demand that is happening now and in the future. Okay. So what that present different opportunities. So on the age we talked about, so today, I don't know if you know this, but the people who are above the age of 60 in UAE is about 1%. in 10 years' time, that 1% is going to go to 10%. 10%, that means above the age of 60, it's going to be 10-fold increase in the number of people that need healthcare from chronic disease point of view, but also present an economic potential for healthcare life sciences. That's why we see healthcare and life sciences as one of the key drivers at the local level, at the global level, for a healthy economy. Also, we looking at the, you probably heard it this morning, and you will hear it today, and you will hear it tomorrow, about the precision treatment, the longevity elements, and all the innovation that is happening in that space that is not only impacting the length of how long people is going to live, but also impacting what sort of quality of life they have and what sort of innovation they might be experiencing later. Of course, about the big data. So in the old days, when you are trying to discover a medication, what you do is somebody will go to a university and do a PhD for about 3-4 years. And along in that period and after the finish of that period, they will come up with either what we call a target, or they come up with what we call a molecule to treat that target. What happened across the last 150 years of modern medicine is basically there are millions and millions of molecules that got discovered and millions of targets that got discovered. The problem with these, they are existing in small pockets in different universities around the world. What the AI and the big data is allowing us to do, حبيبي خبلتني ترى يعني وين ما اروح التجارة. هدي والله. آسف. So قطعت أفكاري خلاص. So what this allows on the computational powers that allows us today is to bring all of these molecules, being it from the target point of view and the molecules point of view, and put them in a computer, design an algorithm around it, and try to discover the new ways of medication. So for example, everybody heard about Manjaro and Ozempic, and more so Dr. Safwan will say, damn it, damn Manjaro. But anyway, so what we're saying is this is one of the medication that came on the back of drug discovery enabled by higher computational powers and higher AI-enabled drug discovery. And more will be happening. So probably you will hear tomorrow about the effect of statin in terms of longevity and enabling cells to live longer. You will be hearing about different medications, the senolytic or the senomodulation elements that are being discovered, repurposing old molecules. So that's all enabled by the AI and big data. Okay. And then what we also have is the investment that we are seeing coming. So today, as we speak, $200 billion get invested in healthcare every year, about 80% of which goes to what we call the P20, the highest ranking countries in terms of attracting these investments. So the likes of the UK, US, Singapore, Ireland now, Korea as well. And what's happening is more and more that playing field is getting even. So many countries nowadays are attracting more investment, including the UAE, into that area. So we talk also about the longevity. The longevity, as you see in the graph in front of you, this is the life expectancy for the wider world that is reaching around 72, 73. But also what you have is the life expectancy for countries like the UAE. And now you've got a full dedicated entities like Pure Health saying our aim, our North Star, our existence, the reason for our existence is going to be longevity. And already driving for the next generation, the one that is going to be born in the next 7 years, to design a system to get that generation, at least 80% of which, to live longer. So a change in the model of care, a change in the approach to care, a change to the approach to prevention. And when that happens, so although you see still the life science investment and the healthcare investment is mostly and continue to be focusing on the oncology side, what we see is the highest percentage of increase is on the prevention side, as well as providing treatment in the lower end, which is the obesity. So that's another area where we see a big increase. We'll come to that and probably talk about it later. So in healthcare, as we know it, and most of the people here, works on your right-hand side of the screen, which is about providing care. So you provide care to people when they become sick and when they seek your help. But more and more, what we are going to see in the future is on the left-hand side, which is the wellness, the prevention, and the monitoring of oneself and having myself taking care of my health. And that is going to be done through the new innovations around genomics, around the genetic testing, around the predictive analysis, and we talked about the AI, and about the microbiomes and the rest. On the other side, we also will be bringing people back to being healthy quicker and better. So through new innovations in cell therapy, nanobots, gene editing, pharmacogenomics. Pharmacogenomics is one of my favorite things these days. I always have favorite things every day. But my favorite thing, which is about taking the medications and identifying, do these medications work on the right individual? So today, many of us, maybe I will start in the next couple of years, use a statin. Statin is a medication that was studied, proven, and went under clinical trials in the US and Europe. What it showed that it's effective to about 90 degrees, 92 degrees. The problem with this is when you translate that into a population like the Middle East, that efficacy dropped to its boots. So the efficacy of statin in the Middle East is about 40%, 30%. That's why we have so many people, especially the internal medicine doctors among you will identify with this. You have many of your patients who have high cholesterol.
Dr. Amar, we have few minutes left. Thank you very much. We have few minutes left.
2 minutes, inshallah. So that's why the pharmacogenomics will be enabling to match the genomes of the individuals to the medication, being it statin, being diabetic, being the rest. I think what I'll go to the end, if allows me. So I'll go into the conclusion. So the conclusion is what we have is personalized health and prevention. What we'll see very soon is the pre-birth gene editing. We're already seeing it through initiatives like the premarital screening that is happening in the UAE. Premarital genetic screening is identifying if thalassemia exists in the potential parents, if there are any other diseases that genetically, with the existence of the two parents, will be leading to complications for the children when they are born. And what happens after that is they allow them to marry, but with the conclusion that they need to seek genetic counseling and potentially gene editing when they are going to have kids. And then what we also have is the precision treatment and management. This is already happening. So we already have patients in UAE today and across the world that get a sample of their tumor taken. That sample gets sent to the lab. The lab will do a matching using AI and using computational powers to identify what's the best treatment, either from existing protocols or from non-existing protocols, so what we call research and experimental, and allow them to have that precision treatment to that individual, to that tumor. And we're also seeing elements and new technologies coming, which is around the continuous glucose tracking, the CRISPR technologies where the gene editing is happening in these areas. The next is value chain evolution. Every technology, when it comes, it shouldn't be put or imposed on the top of existing processes. Processes of what we deal with today need to change. An example of which is what happened during COVID. So during COVID, most of us only experienced the vaccine that gets stored, transported, and distributed at 2 to 8 degrees. Now, what happened is with the Pfizer and the Moderna and even the Sputnik is the temperature that needed to store, distribute, and transport dropped down to -20, dropped down to -80. What this does is not only we are not experienced, it's something that I haven't seen before in my life. And not only me, the nurse, the doctor, the manager, the store manager, all of them didn't experience these things before. And then in order to do that, we need a whole new training for our ways of dealing with these things, an example of which is what we talk about. Last but not least is the novel ecosystem partnership. Today, medicine should not be confined to the walls of hospitals and clinics. In order to treat the
Dr.
next
Omar,
generation and to deal
we
with
are
the
enjoying,
challenges-
but the
Yes.
time, please. Thank you.
Well, I'm finishing. So in order to deal with the challenges and the technologies that are coming our way, we need to have a new partnership. So the science can be only unlocked to the full degree of its potential when it is collaborating with another science. So medicine, biology, physics, chemistry should all collaborate together to cope and introduce the next wave of innovations for our patients, for our society, and for our community. With that, thank you very much, and apologies for that.
Thank you very much. We're going to talk if the robotic surgery is the future in urology. Let's see. So this is my disclosures. This is a picture of my hospital, Mediclinic City Hospital, which is a tertiary hospital. This is our Cancer Comprehensive Center, Mohammed bin Rashid University, and our robotic center is the only center of excellence in GCC certified by Intuitive Surgical. So the simple question, if the robotic surgery in urology is the future, is actually no, because it has already arrived and is well established. So if we look at the milestones in robotic surgery, 1999, the first Da Vinci system was introduced. 2000, FDA cleared the Da Vinci system for laparoscopy, but it targeted the heart but hit the prostate because it was designed to begin with heart surgeries, but actually it took over by the urologist and started to do prostate surgeries. This is a picture from my previous hospital in Stockholm where the second robotic surgery done in Europe at 2002. So this is a part of the history, it's not the future. In UAE, we can see that, can go back. The first robotic surgery actually was done in November 2014, not 15, at Al-Qasimi Hospital, and it was a cardiac surgery hospital. But the program didn't took speed until 2019, where they started to do more gynecological surgeries. So the milestones of robotic surgery, it is a 24 years journey of learning and development. You can see here in 1999 was the first Da Vinci system. In January 2006, the Da Vinci S system came. In 2009, the SI system came. In 2014, the XI system, which was a revolution for robotic surgery because it was a multi-quadrant access. It's improved the ease of use. It was an integrated Firefly technology with a three-dimensional imaging. And then further, they developed the Da Vinci X system, which is a cheaper robot than the XI. It has only 3 arms and the single port, which you can see here how the single port system is working. And now in some centers in the world, they are doing the transvesical robotic prostatectomy with this single port technique. Finally, last year, the Da Vinci 5 system announced it is the most advanced robotic system in the world, which is really ready for AI in the future. But unfortunately, it's not available in this region yet. Hopefully, in the beginning of 2026, this system will be available. In one picture, this is the history of the intuitive surgical robots. We had, of course, the question is why robotics in urology? Because this technique offers several advantages. And of course, radical prostatectomy was the first procedure. We had huge problems. The male pelvis is a narrow pelvis. You cannot walk. Difficult to see. It's difficult to suture in the pelvis. So this is why this procedure gained the urologist started to do these prostatectomies, and with a robotic radical prostatectomy, you have a shorter learning curve. It can be adopted by surgeons without laparoscopic experience, and I would say even without an open experience. I started my robotic surgery doing prostate, and I had no experience in open prostatectomy. Its control of the instrument is less tiring and easier than laparoscopy. Again, we can see the three-dimensional imaging and the tenfold magnification. You can see the motion scaling, which is some sorts of tremor elimination. So even surgeons who have a tremor, have a problem with the hands, this will not transfer inside the patient. The EndoWrist technology, which is very useful in narrow spaces to dissect, to suture, make your life much more easier, your surgery with much more precisions. Of course, it can offer the minimal invasive benefits like a less pain, increased the safety, faster recovery, less tissue injury, less scarring, and precision in performance. This is why this method was hugely adopted, and you can see the late majority adaptation was around 2012 and 13. This is a nice article comparing the results and the complications between open laparoscopic and robotic-assisted radical prostatectomy, where they looked at the operative time, the length of the stay, the estimated blood loss, the catheter time, the conversion to open surgery, blood transfusions, and complications. And all these are the high-volume surgeons, whether if it is for open laparoscopy or robotic. And you can see that the operating time, the estimated blood loss, the complications, and the positive margins was for robotic surgery. Here the same with the complication, the leak of the anastomosis, the infection and the organ injury, and the incidence of DVT in these patients. But it has been shown that the outcomes after prostatectomy is dependent on both surgeons as well as hospital volumes. It's very important to achieve better outcomes, to have a skilled surgeons with a high volume and a hospital with a dedicated team for robotic surgery. Again, we had a problem with robotic surgery because only one company until 2019 dominating the market. But since then, robotic systems start to evolve. And here, 3, maybe 4 systems is worth to name. The Revo system, a Korean system, which is a very nice system. The Hugo, the Medtronic, revealed the first version of robotic surgery. And we have the Versius, which is the CMR surgical system. And then we have the MedPod, the Chinese system, which is actually a very nice copy of Intuitive Surgical. When you sit there, after 5 minutes, you didn't realize that it is a Chinese system. It is just a perfect copy of Intuitive Surgical. Whenever we speak about robot, of course, we speak about the cost of the surgeries and the cost of robotic system. And of course, to calculate this, it's difficult, but we have a fixed cost that you buy the unit, you have the consumables, but then you have the variable cost because the patients stay less in the hospital, 90% going home at day 1 after the surgery, less painkillers, less blood transfusions. All these costs need to be done. In some countries, these patients need to go back to work, to pay taxes. So all these need to be estimated because the cost can be cost to the hospital, to the payer, to the patient, or to the society. So if you choose a technique, if it is good and cheap, it couldn't be fast. If it is a fast and cheap, couldn't be good. If it is good and fast, it couldn't be cheap. And the concept, the Iraqi concept, harum gassibu rakhis, it doesn't exist. There is nothing harum gassibu rakhis. In the calculation of the cost, we are usually forgetting the surgeon, the ergonomy for the surgeon. If we look at the open surgery, you see how the surgeon have a problem with the shoulders, with the neck. The same with laparoscopic surgery, but robotic surgery, of course, offer better ergonomy for the surgeon, and you don't need to be scrubbed to do the surgery. Telementoring projects, I was happy to be involved in the first World Project 2012, where we tried to connect 2 hospitals in Stockholm with Guy's Hospital in London to have your mentor on distance, either all the time with you mentoring, guiding you through the surgery, or on demand when you are just, finished your fellowship or training and start your cases. You may face difficult cases, and then you can call your mentor. They can watch through the laptop, guide you through the complications. Again, this is not the future. Telesurgery using 5G networks, it's a reality. This is one of the first surgeries done between Shanghai and Orlando, but you need to have a reliable fibers and a reliable 5G networks to perform these surgeries. Intuitive Surgical, for example, have an app that I can track all my surgeries, the time of my surgeries, and the time for each instrument I use to have a chance for improvement and efficiency. Again, urology has always been pioneering. This is examples of surgery on a human being done between Orlando and Shanghai. For the last 2 months, there was a radical prostatectomy done between Shanghai and Morocco and between Shanghai and Kuwait with the latency of less than 100 milliseconds. So see how amazing that you can do surgery. And for, I think, the last 2 weeks, there is a telesurgery doing through the satellite, and it was a liver surgery. So what's happened with the robotic surgery, especially in a radical prostatectomy, it's changed the field from the maximal invasive surgery to a minimal invasive surgery, and nowadays in big centers, it can be done as a day case surgery. Imagine that you do a radical prostatectomy as a day case surgery, maximal time of catheter, 2 weeks, 3 weeks to less time, and nowadays you put the catheter only 2 days and you can remove it. Infections and load of antibiotic use, and now less infections and almost no antibiotics, not even prophylaxis used in robotic surgery. Please. We are able to do complex bladder cancer and reconstructive surgeries, totally intracorporeal with the robot. We do a complex renal surgeries, removing tumors, only the tumors, saving the nephrons, removing the kidneys, and even removing thrombus in the kidneys in advanced renal cancers, totally minimally invasive using the robot.
Please, Doctor, 2 minutes.
Yes. And of course, in pediatric surgery, I was happy to perform the first robotic pediatric surgery in UAE 3 years ago. I'm not a pediatric surgeon, but we included our pediatric surgeon with us in the team, and the youngest operation we've done on a boy who was 2 years old. See how amazing that you can do robotic surgery at 2 years old. This is an example how the distribution of robots in the region. You can see in the UAE we have 8 robots, 6 in Qatar, 3 in Kuwait, 31 in Saudi Arabia, and 3 in Lebanon. Unfortunately, we hope that Iraq will enter this market soon and promoting for minimal invasive surgery. The future, of course, the future that could be an autonomous surgery be done, including the augmented reality and the personalized surgical simulation is very important for the future. There is different levels of autonomous surgery that you can rely on the robot to do some parts of the surgery, or sometimes in the future, maybe they can do the whole surgery, maybe simple surgeries, AI application, as I said, but we have a lot of problems to solve before integrating the artificial intelligence and autonomous surgery. We have a patient privacy and data security. We need to secure accountability and liability and the bias and fairness. It's very important. There is a lot of committees around the world discussing these guidelines. They are trying to put guidelines to save our patients. Again, robotic is the new golden standard. You see how our phones has developed. There is no U-turn in this place. This is maybe a bold statement, but I think the only thing need to be open in surgery is our mind, because our minds are like parachutes. They only work when they are open. So the window for open surgery in the future will be very, very, very limited. And of course, having this car will not make you Lewis Hamilton, which is the Formula One champion, and having the robot will not do you. This is Peter Wicklund, my mentor. He's one of the pioneers of robotic surgery. because a fool with a tool is still a fool. So we need to train properly our surgeons to deliver the best results. My take-home messages is that robotics is the new gold standard in urologic surgery. It is safe and effective. It is here to stay and develop, and it is cost-effective and even better results in the right hands. And thank you very much.
Thank you, several organizing listening presentations. My great pleasure to present Professor Dr. Rasid Ayani, Professor of Medicine and Consultant Interventional Cardiologist for American Board of Cardiology and Senior Consultant at American Hospital of Dubai. This presentation video of animal invasive therapies and management of biofilm RBCs. Let us welcome Dr. Rasid Ayani.
Let's go to my acid. Yes. Thank you very much, Dr. Nutt. It's a pleasure to be here. I'd like to again reiterate that شكرا تعالى لمرانا استضافتنا المؤتمر سواء for excellence سواء when you looked up for your one speech and going way out that we wanted to show them. I'm very good. I want to also thank the organizing committee for putting such a wonderful meeting, and special thanks to my good friend Dr. Yahya Kiwan and for Estabatam, and it's my honor to be with colleagues of different age groups who are like seniors, middle age and juniors. I'm not going to say we're at one, but someone will be shy. My task today is really to talk about emerging role of minimally invasive surgery or strategies in treatment of a specific disease in the cardiovascular area, which is aortic stenosis. I have no disclosures other than that I'm from Viva, and this is my journey. I'm from Baghdad, and I moved then to the United States, where I trained in Tanvate, and to Detroit. And from Detroit, I spent about 19 years of my life in the United States, and then from Detroit all the way to Dubai, and who knows, inshallah, someday back to Baghdad. Aortic stenosis is a condition that has to do with the exit valve of the heart, which is the most important valve of the heart. This is the valve that separates the heart from the aorta. Most of my colleagues don't, but I just want to be a little basic. So when this valve closes, you can imagine how much pressure this exerts on the heart itself. And there's a lot of bad sequelae that comes from this, starting from heart failure to all the way to sudden cardiac death. This is a paper from Eugene Braunwald, who is one of the godfathers of heart disease, tells us the history of aortic valve stenosis. It has a very latent, long phase. Could run years of asymptomatic, no symptoms at all, but then symptoms starts to occur. And these symptoms are particularly three: heart failure or shortness of breath, chest pain, and dizziness. And once these symptoms starts to occur, then you can see the Kaplan-Meier curve, or the longevity precipitates in the next 2 years with a 50% mortality. So the take-home message from this slide is once aortic stenosis starts to show its face with symptoms, treatment has to be initiated. How do we diagnose aortic valve? There's echocardiography. It's a very simple test. We can identify the narrowing of the valve. We can identify the degree of narrowing. We can put it in 3 buckets: mild, moderate, severe. Severe is where we start looking at it closer, and then we intervene when the severe becomes symptomatic. Therapies for aortic valve are very limited. There's really no role for medical therapy. As you can imagine, it's a mechanical problem, so you cannot treat mechanical problem with pills. Traditionally, surgery has been and still is a very valid therapy. My role is to share with you, introduce to you this concept, the concept of minimal invasive therapy, where today we can and have been for the last 15, 20 years, replace the aortic valve through a small, tiny hole through the groin, and the patient goes home the following day. Now, why this was born? Historically, aortic valve surgery has been offered to all severe aortic symptomatic patients. However, looking at literature and the data, there has been a lot of patients who did have the condition and was not offered surgery. And this was the inception of the minimal invasive concept.
Why? Maybe because they're old, maybe because had a lot of comorbidities. So there's definitely a huge need that was not met. Surgery is well established, has a morbidity of 2%. Some people receive mechanical valves, so it does come with a long-term therapy of anticoagulation. I'm not here to say surgery is bad. Surgery is actually the front line of treatment for aortic valve surgery, but until the TAVR came about, which is the transcutaneous approach. This led to the revolution of TAVR, and these are two examples of valves that are out there today that can be implanted through a small hole in the groin, and the patients go home, and we put this new valve inside the old valve without having to do any open heart surgery. I want to emphasize two things. Patients go home the following day, and this is done under local anesthesia. I always show this slide to my patients. You can have a zipper in the front chest, or you can have a small tiny hole in the groin and go home the next day. The approach is we come from the femoral artery, we go all up to the aorta, make a turn in the aortic arch, go inside the valve, implant the new valve, come out, close the hole with a small suture, and the procedure takes about an hour. I'm not sure if we can click on that link. Okay. All right. We'll just go ahead. So again, the trial that paved the road for TAVR is looked at different sections of multiple risks. I'm not going to bore you with data, but these are the scientific evidence base how TAVR made it today to the front field, and today TAVR is one of the first alternatives for people who have severe aortic stenosis, especially if they're age above 65. These are just Kaplan-Meier curves showing you one message, that TAVR was tested against surgery and they came out to be equal. And I'm just going to go through these slides, and you can see the same theme, that the curves overlap, stating that there is no non-inferiority of TAVR when compared to SAVR. And this is across multiple risk groups for patients. Now, does the valve have a long-term durability? And in these trials, they actually looked at surgical population and percutaneous TAVR population, and they saw how the valve performed over 5 years. And you can see, again, the curves overlap for performance of durability of these valves that are done through the groin versus the traditional surgical valves. And this has been replicated in the two products that I just showed you, whether it's made by Medtronic, which is the self-expandable, or the Edwards, which is the balloon expandable. So today, TAVR is for all, but not quite. We still have those two sick, two old patients who are very frail, and these people you may not want to offer them anything, because it is a simple procedure, but does carry some risk. So there is always this futile two sick patients where they shouldn't be getting anything. But if you have high risk, if you have intermediate risk, if you have low risk, and if you have a extreme risk, all of these patient population have shown to benefit from TAVR in a randomized trials that I just showed you. This methodology has been adopted by multiple societies, including the Thoracic Cardiovascular Surgery Society and the American College of Cardiology and the European Society, and it's a worldwide therapy provided and offered to patients. So when we look at patients with aortic stenosis, we ask ourselves 4 questions. Number 1, is this severe, and is this symptomatic? Because if it's not severe, or if it's severe and it's not symptomatic, you can wait, because I just showed you the curve earlier on that these patients have a pretty steady longevity until symptoms starts to occur. And once that happens, then you have to move, and you have to move fast. The second question, what is the risk profile of patients? Now again, aortic stenosis is a disease of elderly. You rarely see aortic stenosis in 30 and 40-year-olds, right? We see them in 60, 70, 80, 90-year-olds. So how far can you push this therapy is a very important question, because at the end of the day, if you have a very frail patient, then leaving things alone may be the right thing. And that's a very important message to young individuals, practitioners out there who are trying to build their experience. TAVR needs to be done in those who are acceptable risk. And I always remember one of my mentors once told me the best cases that you do are the ones that you avoid. The third question is we do a CT scan, because CT scan is very essential to size the exact valve and see what is there out there and pick the right size for the right valve. You never want to put a valve too big or too small. And finally, we have to look at the peripheral circulation. You know, in the United States, when you become a TAVR operator, you have to be cardiologist, you have to be interventional cardiologist, you have to be a peripheral interventional cardiologist dealing with iliac arteries, and then you have to be a structural cardiologist. So you can imagine structural heart disease or TAVR operators have to build all that experience, because it's not about just doing this 80, 95% cases, but also is about being able to navigate through the 5% complicated cases and be able to save the patient when things don't go your way. And without these set of skills, you're really running a very thin line. I want to end with this case. This is an 85-year-old gentleman. This is the first case that I did here in American Hospital, and it was the first TAVR case at the American Hospital in Dubai. You can see his comorbidities, and we run these patients through what we call a STS score, and what that is what is their risk if they go in open heart surgery. And if the risk is above 8% mortality, that's considered very high risk. This gentleman had a mortality risk of 8.6. A morbidity and mortality risk combined was 35. So when we moved on and we actually got him through the, when we added CABG to this, you can actually see that the outcome was very high, even when you put just CABG to his patients, which he had before, CABG meaning a prior open heart surgery, which adds another element of risk that increased the mortality to 11% and 42%. This is the gentleman. He did very well, remained in the hospital ICU for 1 day, discharged home, and I still see him 5 years later. And he actually wanted to get remarried a year later. So I want to conclude by saying that in randomized trials, transcutaneous aortic valve replacement today is equivalent to surgical aortic valve replacement across all risk patients. Mortality is the same, stroke and NYHA class is the same. TAVR valves did show durability 5 years, and we have data now out to 10 years that these valves do stay functional and are parallel to cohorts of surgical patients. There is a little bit of a pacemaker rate that's higher than the surgery, which is something that's acceptable, and we tell this to our patient. That risk is now less than 5%. There is also an element of paravalvular leak, which is less than 1%, and there are some methodologies you can do intraoperatively to correct that before you leave the cath lab. And finally, both devices that are now available, actually there's now a third device, I'm talking about FDA approved, that are now available for these therapies. So TAVR is for all, and it has been an acceptable treatment today for all symptomatic severe aortic stenosis. It's a preferred method for extreme strict, and it should not be considered for futile patients. This is very important. And finally, there's a lot to be learned about the role of this therapy in congenital aortic stenosis and aortic regurgitation. This is the leaking side of the valve, and there are some trials that are showing that there is a role for TAVR even in AI that was just published at the TCT meeting last October last year. But that's remain to be seen. Thank you very much, and I'm happy to entertain any questions.
And an active researcher, our colleague, Professor Dr. Muhannad Al-Ansari, consultant surgeon, specialist in general surgery, minimal invasive GI surgery, and robotic surgical oncology. He's a founder of the Space Tele Surgery Center in USA and AI Magna Gracia University in Italy. At time, he's a consultant at Canadian Hospital and Al Shifa Surgical Center. He will present his lecture. His presentation will be updated in the space tele, medicine, and space telesurgery. So within the frame time, Doctor, please.
Refers to the delivery of healthcare services and medical support to astronauts and the space personnel using telecommunications technology. It involves monitoring health conditions, providing medical devices, and facilitating remote consultation between healthcare professionals on Earth and those in the space. This important health issue that may arise during long duration in a space mission, ensuring health and maintaining the well-being of the crew members. Space telesurgery, which is a surgical procedure performed by a surgeon who is not physically present at the patient location. Instead, the surgeon operates using a robotic system or a telecommunication technology to manipulate surgical instrument remotely. This method allows for specialized surgical expertise to be applied in location where it might otherwise be unavailable. طبعا الآن الجراحات من بدت سميت بجراحات الخيال في البداية قبل حوالي 10 إلى 15 سنة نتيجة قلة الأجهزة وقلة الخبرات. الآن هذه الخبرات مكنت الجراحين من توفير خدمة جراحية محترفة لمناطق الأطراف وعند عدم تمكن الخبرة الجراحية الموجودة. The history of space telemedicine in the early research started in 1960. The concept of space telemedicine emerged during the early space program mission by NASA. In Apollo program from 1960 to 1970s, during the Apollo mission, NASA began to implement a real-time health monitoring system and a medical team trained to able to provide a medical and health guidance to support the astronauts on these vehicles. In 1973, the Skylab, which is the space station, provided an opportunity for more advanced health monitoring system. The International Space Station in 1998 started until present. تم بناء المحطة الفضاء الدولية سنة 1998 واستخدم بها الذراع الروبوتي كندا آرم 1 وكندا آرم 2. والحقيقة دقة هذا الذراع الروبوتي في تجميع هذه المحطة قادنا إلى تأسيس الجراحة الروبوتية. العلماء اجتمعوا ومن شافوا دقة هذا التصنيع وكيف تم تصنيع هذه المحطة اللي كلكم شايفيهم we'll see its picture. قالوا إذا صغرنا حجم هذا الذراع الروبوتي واستخدمناه لغرض إجراء العمل الجراحي سنبدأ وفعلا هذا اللي صار. After that, the research developed advanced communication technology such as high data when the virtual reality came and the artificial intelligence that we will see later on. And these are the picture. This is the Skylab, 1973. This is the Apollo program, 1960, 1970. And this is the ISS, 1988 till present. طبعا هذه المحطة راح تتقاعد خلال سنتين والآن عندنا محطة الفضاء التشاينيز سبيس ايجنسي ونفكر العلماء مع ناسا لبناء محطة دولية أخرى. The history of space telesurgery, an early innovation in 1980s, foundation of telesurgeries were laid by the 20th century of the development of robotic systems and video conferencing. The first remote surgery in 2001. في سنة 2001 تم إجراء عملية جراحية بين نيويورك و recognized surgery procedures. It was done between New York and France using a robotic surgical system. وكان نجاح علمي وبداية لثورة علمية راح نشوف. The advancement in robotics in 2000 as I told you سنة 2000 بعد بناء المحطة الدولية سنة 1998 ودقة الروبوت الكندا آرم 2 وعندما تم تحويره إلى روبوت مصغر تم إطلاق شركة دافنشي انستيتيوت وإجراء وبداية الجراحات الروبوتية. Military and remote application started in order to prepare an advanced surgical care for the soldiers in which that there is lack of surgical expertise and the current trend. And here this is the history where the first robotic telesurgery by Professor Jacques Morisco and Professor J. Leori. You can see he is sitting in France and in New York and the patient is in France. It was a robotic cholecystectomy and it was a great success. After that, Professor Mahran Ambari, one of my friend, he is in Canada. He started a series of telesurgeries between the submarines في المحيطات وفي أعماق المحيط، وأيضا في مناطق كندا. اللي يعيش في كندا أو يشوف الخريطة الكندية هي عبارة عن مناطق بها مناطق نائية وصعوبة لتوفير الجراحين. فتم اعتماد سيستم مع الحكومة الكندية وحقق نجاحات باهرة، وإلى الفضل أيضا في تأسيس الجراحات اللي وصلنا إلها. سنة 2010 دولة الإمارات العربية المتحدة، الدولة اللي نفتخر بوجودنا بيها واللي تدعم العلم والعلماء، وفي جامعة حمدان بن محمد بعد نجاتنا من أحداث العراق، وتم تكليفنا بتأسيس في مؤتمر الصحة العربي سنة 2008 كان أول ظهور للجراحة الروبوتية عن طريق المحاضرات. سنة 2009 وسنة 2010 الجامعة طلبت من عندنا إجراء أول جراحة عن بعد باستخدام الروبوت دافنشي، وتم الاتفاق مع البروفيسور كوستانتينيدس في مركز أثينا، والفيديو موجود على اليوتيوب، وهو كان أول ظهور للروبوت دافنشي في منطقة الشرق الأوسط وفي دولة الإمارات. وبعد ذلك كان مولد الجراحة الروبوتية في دولة الإمارات. فالفريق الجراحي كان بروفيسور كوستانتينيدس فروم جريس ودكتور مهند الأنصاري فروم دبي. كانت الجراحة هي عبارة عن روبوتيك كوليسيستكتومي دافنشي سيستم، وكان ضوء ليزر أحمر نتبع به الاناتوميكال ستراكشرز على مناطق المرارة، الجول بلادر and the gallbladder blood supply, and the Da Vinci was following us and it was an amazing success. After that a journey continued in 2019. اجى الدور الصيني. الصين معروفين بأخذ العلوم وتطويرها، وبالتالي they started to do a series of experiment and a series of robotic manufacturing. And here we can see Professor Fozio from City China and Professor Antonio Di Lassi from Europe. He was also following كان يرسم على مناطق الشاشات ويتبعوه الفريق الجراحي مالته، اما بالروبوت او باللابروسكوب in order to do a telementoring. The first virtual reality guided telesurgery الإمارات من جديد، دبي. Between Dubai and Tokyo, a work between the Robotic Surgery Academy and Tokyo University. إذا تشوفون على اليمين الجراح مهند الأنصاري يرتدي الكاميرا الافتراضية وكاميرات الواقع الافتراضي، وعلى اليسار حتى صارت بيها نكتة راح أحكي لكم إياها. بغداد معروفة في ألف ليلة وليلة وقصص الجن، فمن طلعت لهم في صالة العمليات في طوكيو فجأة مثل الظل، فالنيرز قالت this is a genie. زين، فقالوا لها هذا من بغداد وهذه قصص ألف ليلة وليلة. فالحقيقة على اليمين هو أول ظهور للجراح بالأفاتار، وكان يقود العمليات الجراحية كانت قص المعدة بالمنظار، وتم إشراف العملية وتم نشرها بعدة دوريات معتمدة عالميا واللي سميت The Virtual Guided Telesurgery. الانوفيشن لاب مختبر بروفيسور ماكي ساغوموتو وفروم دبي مهند الأنصاري. بعد ذلك هذه العلوم كلها جمعت مع بعض، الفيرتشوال رياليتي، الاي اي اند روبوتيك، وسوينا برنامج ارسل الى وكاله ناسا الفضائيه عن طريق مختبر الانترناشونال لاب او المختبر الوطني لوكاله الفضاء اللي اسمه ISS National Lab, and they approved it in which that we are started to provide the primary health care and the surgical care inside the space station and to the moon base بارسال الافاتار عن طريق هذه التقنيات داخل المحطة إذا احتاجوا إلى طبيب، وأيضا الذراع الروبوتي اللي راح نشوف تجربته اللي يقاد عن بعد بكاملات الواقع الافتراضي أو بشبكة الواي فاي. هذا الإقرار من ناسا واعتماد تقنيات الواقع الافتراضي والذكاء الاصطناعي والفيرتشوال رياليتي لتوفير السبيس تيليميديسين أند تيليسيرجري. بعد ذلك تم تأسيس The Space Telemedicine and Telesurgery Center in USA. هذه طبعا صورة المركز يعتمد على تقنيات متقدمة جدا بالذكاء الاصطناعي والروبوتات والواقع الافتراضي والنقل الافتراضي للجراحين داخل المحطة الدولية. نفتخر أن دولة الإمارات الآن هي أحد 12 دولة في بناء المحطة القمرية، وأيضا الآن عندنا سيستم متقدم وهو توفير الرعاية الطبية والجراحية للمحطة القمرية عن طريق هذه التقنيات. التطوير صار أكثر مع وكالة الفضاء الإمارات، قدرنا واستطعنا ربط الأفاتار مع الساتلايت، وهذا الأفاتار مزود بالذكاء الاصطناعي بسيستم اسمه الأفاتار المقاد بالأقمار الصناعية في مناطق الكوارث. لا سمح الله إذا تعرضنا إلى منطقة كارثة من فيضان أو حروق، الساتلايت تعرفون الموجود في الليو ايرث سبيس او بما المجال الجوي نقسمه احنا 3، فيعطينا صور مباشره لاحداث الكوارث، فيستطيع عن طريق الGPS تحديد المنطقه. مرات انا هذه المنطقه يصير بها إتلاف في الشوارع وإتلاف في الطيران والإنترنت وكل شيء. كيف العمل؟ نعطي شبكة ميليتري انترنت أو سبيس انترنت. تدرون الآن إيلون ماسك وعندنا تشاينا وعندنا الروسيان عندهم الإنترنت الفضائي، وبعد ذلك نوجه الأفاتارز المدرب الأفاتار الفرق الطبية وعندهم أذرع روبوتية لإنقاذ الحياة أو لفتح الطرق. هذا السيستم اسمه الأفاتار المقاد عن طريق الأقمار الصناعية أو The Avatar Guided Satellite System. الآن طبعا أجريت أول جراحة في الفضاء، مثل ما تشوفون الصورة بالأسفل هي إطلاق القمر عن طريق شركة سبيس إكس. الصور بالبوكس هو الروبوت ميرا حيث تم شحنه إلى داخل المحطة الفضائية، وبعد ذلك تم إجراء أول جراحة وتم قيادتها عن طريق الأرض. وبالتالي استطعنا توفير طبيب عن طريق الأفاتار داخل المحطة، ووفرنا ذراع روبوتي يقاد عن بعد. وبالتالي الآن the space telemedicine and telesurgery is a real entity and a real existing. And this is the avatar guided AI. This is the avatar that we are using. واستطعنا التطوير عن طريق مركز البحوث في جامعة ماغنا غراسيا، وهو مركز بحوث الذكاء الاصطناعي والميتافيرس. وعندنا بروفيسور ميشيل اليوم مشرفنا من إيطاليا يمثل هذا الوحدة العلمية اللي تم تأسيسها من قبل مهند الأنصاري. أتشرف بهذا. والآن احنا في طور تصنيع أول قمر صناعي اسمه هيلث 1 ساتلايت، راح يطلع خلال 9 شهور، راح يوفر هذه الخدمات إلى المنطقة، وهو اسمه الهيلث ساتلايت. هذه الجراحة اللي أيضا زميلي تحدث عليها وهي الساتلايت كوميونيكيشن روبوتك تيلي سيرجري والسكسسفul اتشيفد. ومثل ما تشوفون اتباع البحوث العلمية، فالصين الآن نجحت بأيضا استخدام الأقمار الصناعية في توجيه الروبوتات وإجراء العمل الجراحي. طبعا هذه صور، إن شاء الله الفيديو يشتغل حتى نشوف هذه الجراحة. راح تشوفون الأفاتار وكيف واضح داخل sorry I can go back. اوكي، هنا طبعا الصور الفيديو موجود. الذراع الروبوتي في الازرق الطبيب موجود في دبي وهو يقود الكاميرات الافتراضيه. الصوره البيضاء هو الروبوت موجود في لندن، وهو قياده الذراع الروبوتي بين دبي ولندن لغرض التحكم عن بعد. كان استخدام شبكة ال4G، وبعد ذلك تم اعتماد هذه التقنيات. and now the space telemedicine and telesurgery is an existing facility, and this is all about my lecture today. Thank you very much.
And there is no much recommendation from the scientific societies. So now I need your advice. If I am a clinician, we have these modalities of treatment, we have patients, but there is no regulations from health authority, there is no cover from insurance, there is no evidences. But on another side, the people who promote this longevity and regenerative therapy, they say they are very good and good treatment for the long life. So how can we balance in between? The question for Dr. Omar, please.
Okay, thank you. So generally speaking, I know when we talk about longevity, if I can draw back what's happening around the world, there are 3 big buckets of activities happening across the world in terms of longevity. One is about preventing longevity. So we talk about lifestyle, we talk about taking certain medications, we talk about different things that enable us to live a biological age that is less than our age in years. Second is about slowing the aging process. And third, which is happening today, is about reversing the aging process. Now, you take it at everything we say in medicine happens at the molecular level, at the cell level. In the cell, there are 2 main things happen and lead to longevity, to let's say, cell aging or us aging. One is at the molecular level within the nucleus. The DNA become a bit older, and what it does is typical of any command center. It starts firing ideas and firing commands that are not good. And second, what you have is what we call the mitochondria. If you remember your early basic science years, mitochondria is the place where energy gets generated. So it's the engine for the cell. What happens is with mitochondria, it starts, let's say, some days working, some days not working. So it's like a ship. So the command of the ship is not giving good orders, and the engine of the ship is some days it works, some days it doesn't work. And what happened to the ship, it doesn't go anywhere. So one wave get it this way and the other wave get it this way. And what's happening today, the application of this, the biggest, and there are lots of theories, but some of them are getting to the stage of being applied clinically. So nowadays you probably heard about the multi-omics and the omics and the different analysis of different parts of the body, including the guts, including the skin, including the blood, to identify what's happening at the molecular level, at the genomic level in the body, and then having applications. So today in MediClinic, in HealthPoint, and I think, I'm sure there are also in Dubai, they provide a long term of analysis of what's happening to the body, what's your biological age, what's immunological age, and then transfer to some application. The promising applications is a group of medication. They are called senolytic or senomodulators. Senolytic is not preventing, but kind of taking care of certain cells that exist within all of our body. So the cell, when it ages, it starts going into a place where it's not dead, but it's not functioning properly. It's what we call, or the Japanese call, the zombie cells. It's actual scientific name. It's zombie cells. So the senolytic will be trying to target this, and senomodulation trying to target. So there are applications already happening in that space, and of course there are many other applications for the skin, for the gut, for the heart, and the invention of new, the repurposing of new medication, including the statin, the HRT, and the rest of it.
Okay, thank you very much. Question from Dr. Yahya Kiwan.
Actually, if you allow me, I just want to comment about the second part of your question to Dr. Omar.
Yes.
He said, is there any evidence about regenerative medicine application and in the guidelines and so on? I will have a presentation tomorrow about the evidence-based clinical applications of stem cell therapy in all medical, surgical subspecialties. I'll try to review and answer your questions. Do we really have evidence-based application, or we are just talking like, nonsense? So I just suggest all of you, if you are available tomorrow, that I believe I can answer most of the current questions about the
Dr.
application.
Yahya, honestly, like I will tell, to be more representative, I will speak about urology with you. So like for regenerative therapy, we have stem cells, we have shockwave, we have PRP, and commercially, a lot of people, they are saying it is a perfect and we have very good responses. But if we look for the studies that some of them label it like evidence-based, all of these studies, I can tell you that they are very short follow-up, very small samples of patients, and there is subjective rather than objective evaluations of the responses. So at the end, this considered having very high, large bias conclusions. What do you think?
That's why tomorrow I can show you the literature, the study, the article, the date, the number of patients, the result, the follow-up, 1 year, 2 years, 3 years, 5 years. So if you call it intermediate term or long-term follow-up, that's what is currently available. Of course, I'm not saying they are 100% good, but at least we have some evidence that regenerative medicine and stem cell therapy, it is going on, and I will show you the literature over the last 2 decades. Whether objective or subjective, they are really objective, and we should wait till tomorrow.
Okay.
I think, Dr. generally speaking, we keep talking about longevity. Longevity is as old as the world. يعني قلقامش من أيامه يدور longevity. يروح all the way to the end of the world seeking for eternity and then getting with نبتة الخلود وبعدين يضيع نبتة الخلود the rest is history. بس يعني in between that day and between today, There's lots happen, lots of hocus pocus, but I think this time is different. Then there is a lot of science behind it. There's a lot of science seeking for it. And when we talk also about longevity, we need to narrow the term. Then longevity is a very broad term. Yani everything that we do in medicine could be said to be contributing to longevity, from taking the vaccine to eating healthy to getting stem cells injected into your body. All of them contribute to longevity. But the thing is, we need to focus on the reversing part, and that's where the exciting of the science happening.
Okay. The questions for Dr. Mother, definitely robotic surgeries is revolutions in the management of many conditions, but also still many restrictions and barriers, whether from insurance cover, about the cost, about the training of the professional to get on high-skilled. So also there's limitations of the performed cases that could affect sometimes the outcome. How you can balance in your work between all these barriers and the outcome of the patients?
Again, the implementation of robotic surgeries depends on your healthcare system, and one of the most important factors is the skill of the surgeon, as we spoke about. Of course, the insurance company maybe is an obstacle sometimes, but I think they are realizing that this is a part of a good practice that need to be implemented and reimbursed in a good way. Of course, the number of cases is a challenge, maybe in some specialties, in some regions. This is why maybe implementing this type of surgeries should be centralized to collect all these cases to get better outcomes.
Okay. Thank you very much. At the end of the session, I thanks all of you, and I think this is time of the lunch, and we'll distribute also the certificate between the speakers. So please, you can enjoy the lunch, and we'll go back at exactly at 2 p.m. Thank you.
الإمارات العربية المتحدة، دولة التعايش والتسامح، ومن إمارة المستقبل دبي الفتية، وبرعاية معالي الشيخ نهيان بن مبارك آل نهيان وزير التسامح والتعايش والرئيس الأعلى لجمعية الإمارات للأمراض الجينية، بدعم من هيئة دبي للاقتصاد والسياحة ومؤسسة الإمارات للخدمات الصحية التابعة لوزارة الصحة، وفريق شكراً لعطائك والراعي البلاتيني فارمالاب وAMS. تستضيف دبي جائزة باو والمؤتمر الطبي العراقي في اليومين 24 و25 من شهر كانون الثاني يناير عام 2025، والذي يعقد في مكتبة الشيخ محمد بن راشد آل مكتوم، تماشياً مع توجيهات القيادة الرشيدة لاحتضان العلماء والمتميزين من بلاد العالم، والتي تعكس الرؤية التي أرساها المغفور له الشيخ زايد بن سلطان آل نهيان طيب الله ثراه للاحتفاء وتكريم الكفاءات العربية التي ساهمت في خدمة الإنسانية. خصصت الجائزة في دوراتها الأولى لتكريم أبناء الرافدين من الكفاءات والمبدعين من حول العالم. من المكرمين في هذه الدورة الدكتور علي الحرجان، استشاري الطب النفسي الذي أرسى النسخة الأولى من هذا التجمع العلمي، وسيتم تخصيص كل دورة من الجائزة للاحتفاء بالكفاءات من دول عربية مختلفة.